Thank you, Eva, for inviting us. We're very privileged to be here. And thanks, Hans.
It's always the same.
We're very privileged to be here, and thanks everybody for attending to listen to all the speakers today. That's great. And first thing, 2 steps. First of all, you need to be sitting next to someone. So if you're not sitting next to someone, can you just shift over? 1 seat between you is okay, but we don't want anybody getting lonely, because this is a long session. So just shift around. And the next thing we'd like you to do is to look at the person next to you. Look at the person next to you. And if you don't like the look of them, and you don't want to be discussing anything with them, then you can move again. Because we will try to make this session a little bit interactive. Sorry about that. So the topic we've been tasked to talk about is the burden of musculoskeletal pain, which I'm sure you've all been aware of, the publications over the years, and the knowledge that we are struggling, and people are struggling with musculoskeletal problems. And individually, we may do our best, but sometimes we may want to ask the question, as MDT clinicians, are we really part of the problem, or are we part of the solution? Okay. So, in my mind, we look at this and we think, hey, we do seem to tick all the boxes, right? Yeah. Consistent with the guidelines. We provide exercise therapy, and we add education to that as well. We're all about self-management. That's our focus. That's our key thing that we're really trying to engage our patients with. We certainly give our patients advice to remain active. Activity is what we promote. And we think about the drivers of pain and disability. We try to acknowledge, identify, and address, when we can, the drivers of pain and disability, the psychosocial factors. And we certainly, as MDT clinicians and as clinicians generally, try to be reassuring and encouraging. So really, I think this can be a relatively short presentation because we have it, we can be relaxed. And we don't need to worry. It's for other people to really think and be concerned about whether they are part of the problem, because it's clear that we are part of the solution. Everyone agree with that? Yeah, of course. Part of the solution. Okay. And we have some data to support this. We did a survey with clinicians, and part of that survey was to diplomats, so people that have gone through the whole MDT process. And the question was, does MDT align with the guidelines? And what do they think? And so here we have 96% of people feel that we more align with guidelines, or we always align with guidelines. So that's pretty good, don't you think? 96% of us agree that we align with the guidelines. These are diplomats, and so these are the top, but all credentialed therapists, people working through the courses, we've got it covered. We don't need to worry.
Wow. Is it working? Working? Yes. Yeah, all right, thank you. Well, Richard, I disagree with you. And I have more times that I disagree with you. Because I think you looked very biased. You only looked at those diplomats. You did a nice survey with diplomats. So you can think about that. Diplomats who are doing all that McKenzie stuff, and they go into it and they go deep into it, and then they come out and they will, of course, they will tell you that they are aligning with the guidelines. But we did a survey as well. We did a survey as well. No, go back.
Yeah, that's true.
We did this before, and we tried to do it again, and it's always difficult. But anyway, so we did a survey as well, and we asked people in MSK treatment what they thought about MDT and how it would align with the guidelines. So not people who are trained in MDT, but just have read maybe something about it. Just they were thinking about MDT and how they were aligning with the guideline as their thoughts. So I want you to go to your neighbor, which you precisely have picked out to talk to, and I want you to think about the number of how many people now are thinking that, so non-MDT people, how many of those people think that we align with the guidelines? So give you a few seconds and talk to each other and think about the figure.
These are musculoskeletal clinicians in general.
In general.
In general. Go ahead. Chat. Sorry about that.
You didn't ask that. So
I didn't ask that.
You're so interested.
Completely forgot that. Anyway, we'll ask from now on. Yeah, I didn't ask that. We've got other opportunities.
So, before you start to do your social talk again, so what would be the figure? Is anybody thinking it's above 96%? Nobody. All right. Is it above 60%? Well, okay. Is it above 40%? So between 40 and 60, you say, most of you. So let's have a look at the survey. Yeah, it was 40%.
Okay.
So you think, well, that's not too bad.
Yeah, I think that's not too bad generally.
Yeah,
it's okay. Yeah. Okay.
But we dived in it a bit deeper, and we were looking at people who MSK therapists who were knowing something about MDT, and people who used a little bit of MDT in their treatment, and people who didn't. And if you then look at that data, it's even worse. If you go to the next slide. So the people, the MDT, oh yeah, that's yours, sorry.
That's not so bad, I think. 60% of people generally, that MDT users, generally not diplomats, MDT users, 60% of, I think is good. Yeah, that aligns with the guidelines. I think that reinforces what I thought, first of all. Yeah, no problem.
If we then dive a little bit deeper, as I said, then people who don't use MDT, they think totally different.
So what does everyone think about non-MDT clinicians? How many non-MDT clinicians
who think that we align with the guideline? So talk a bit with each other again. Just the number.
Huh? Yes.
So if we look at that number then, and of course there are people who don't like MDT or have some ideas about it, or they don't know anything about it, but then the number is really different. So it's only 27% of the people that they think keep it close. All right. That's impossible. I will keep it like that. 27% only is then thinking that we are aligned with the guideline. So that's a big difference. So on the one side, the diplomats which are really thinking that they align with the guidelines, 96%, versus the non-MDT people think that we don't. So
you would think that they're looking at different guidelines, but in principle, it's the same guidelines they're looking at. But I would argue, who cares about that? Who cares about what people think? We have our own little MDT world, okay? We speak the same language, we practice the same way, and we're happy. So do we worry what other people would think? I don't think so. I don't care what other people think. I'm happy to practice, and I believe that we're consistent with the guidelines, and it's all good in my world and in our world.
Well, I'm happy in your world, but it's not in mine. So I think it's maybe important to think about, what do we have to share as MDT therapists? Do we have to share anything then? Because we want to have a nice educational program. We want to involve all people, all physical therapists into MDT. So we should have something to share. So if you think about that, and tomorrow you would talk to a person who doesn't have any MDT training, what would you like to share with that person to make him more attracted to MDT? So you can talk.
Or what would you think is valuable that they should know, that you know, and you think you can pass along?
So talk to each other again for a few minutes.
I'll give him a little bit. Give him a little bit longer.
Okay. So you were talking about what you can share. If you look at the next slide, was there anything which you would share with your non-MDT trained therapist, which is in this list? Because that's our core values. That's what we try to educate. So that maybe it's interesting for others to listen to this. And how do you think people are going to respond? Well, maybe some people, they are not listening at all. They don't like to listen. And of course, they're always there. But maybe by sharing things and by saying where we're good at, and maybe we think we can add some value to the therapist treating a patient, then it could be that they start to listen a little bit, right? So I think if we want to be part of the solution, we are not going to be the whole solution, but part of the solution, I think we need to puzzle around with other people outside the MDT community to get them more interested in it as well?
Yeah, I mean, maybe there is a point to that.
Oh, thank you so much.
Yeah,
That you start to change
I mean,
it.
I've heard something recently along the same lines that, you know, maybe we shouldn't work independently so much in silos, and maybe we should be open to more collaboration and cooperation. And, you know, maybe, yeah, we do have things to share with people, but also maybe we have things to learn from others with other approaches and perspectives and philosophies. So maybe this is more of a two-way street as well. Maybe.
I'm happy
That's
you
okay.
slowly start to change a bit. All right? So, because it's the question, do we always provide high-value care? Maybe we can learn from others to promote that high-value care. So, do we always targeting those problematic areas, domains in the psychosocial area of a patient's story or the experience of the patients in pain?
And I would say, yeah, we have that covered. We have on our forms the drivers of pain and disability. We're aware of those factors that could potentially influence the outcome and affect the patient's perception of pain. So we're good with that. We have that covered.
Well, do you think so? Because we did another survey under diplomats, so the people who are really highly trained. And yes, there are people who are looking at it, but not everybody is looking at those drivers of pain and disability. So maybe we can do a little bit better. Maybe we can use more those questionnaires to figure out really specifically what's going on with that patient. Maybe we can use that more than we did before.
Yeah, I mean, it is disappointing that a good chunk of people only rarely use those outcomes for sure. And so you look at that and you think, yeah, maybe MDT clinicians are not really pulling themselves, you know, to the highest level that they could. But then you can compare it with other clinicians. Look at this. This was a study that came out a few years ago, and 81%, this wasn't MDT clinicians, this was clinicians in general, musculoskeletal clinicians, 81% did things that there was no recommendation for. And 43% did things in their practice, interventions, management, treatment, which were not recommended. So, you know, I think that's, you know, we're not doing badly, but I can see that MDT clinicians would want to aim higher than that. They would want to do things.
To do a little bit better than just going to that stupid figures.
Sure.
Right?
So they want to individualize their care to a great extent, take these things into fact. And I'm going to go through some examples of those, some patients that MDT clinicians have seen
Show me
to show you how care is really individualized. So here we have Mary. She had a derangement. She was given directional preference exercise and posture advice. It was geared towards her presentation, very individualized. And we have James here. He happened to have a derangement as well. He had the directional preference, different direction, but directional preference. We gave him directional preference exercise and posture advice. And then Max here, you know, he was different as well. And again, but he had a directional preference, of course, and we gave him directional preference and exercise.
So
and
it was
posture.
a different direction.
It was a different direction.
Right.
That's right. So it's personalized. And Lee here, derangement, and yeah, she responded really nicely. We made sure we geared it towards her particular presentation, and she had a directional preference, and we gave her posture advice. So, you know, these are examples of personalized care here. So I think that's good. That's good. That's what we do.
Well, that's not bad. But it's all, if I listen to it, it's all on the bio part. It doesn't say me anything on how they are as a human being, how they experience their pain, how they deal with their fear maybe, etc. So if you look at the research, the greatest criticism of classification systems is that people within the same classification always get the same treatment.
But both of these people, say Max and Mary, they both had a directional preference, right? So you know, that's individualized treatment.
I agree on that. You covered the bio part. But I looked a little bit deeper into Max and Mary, because they're very different people. So let's have a look at Mary. Mary, she was really having a lot of contextual factors going on in her life. Her boss was nasty. She was in a divorce. Her children were not having a great time with that. So she had a lot of trouble in her head like that. And she had comorbidities. She was having diabetes. She was having a high blood pressure, etc. So there are more things going on in her life than only that one exercise you gave, right? And then looking at Max to compare, Max was totally different. He had a lot of cognitive factors. He was afraid of moving. He was fearful for bending. He didn't want to lift because his disc would pop out. So all sorts of beliefs, which are maybe if we would have looked at that first and in the treatment of your directional preference would incorporate that, maybe we could have had a better outcome on those two patients, right?
Yeah, I mean, yeah, we seem to tick the boxes then, but maybe we tick some boxes not quite so much as we tick some other boxes, maybe, generally.
Well, you're a little bit stubborn in here, but I think, yes, we do tick boxes, but we can do better, and that's what we were talking about, don't we?
Okay, so we've talked about three different things really where, and of course there are many more, but three different things that maybe as MDT clinicians, maybe we could do a little bit better with, and maybe we could be reflective on in order to do our part. So can you remember, turn to the person next to you, and
this is a test, by the way. So
this is a test. Three things. What were the three things we just talked about where we can really reflect and maybe we can do a little bit of a better job with? So talk to the person next to you, the person you like to talk to. Go ahead. What are the three things? Remember?
You're good. 20 minutes left. Well,
yeah,
15 minutes
we've
left.
done 20 minutes, so we're going to ask general questions and then get to the specific one here. Oh, maybe we do the specific question first here, and then we ask general at the end.
Sorry?
We ask this next.
Yeah.
And then we open up for general questions right at the end. Do you think?
Well, yeah, so do we follow that?
Oh, yeah, well, if we finish this first.
And then?
Yes. No, maybe we open up first and then we do that.
We just finished this.
We finished that, we open it. No, I meant right at the end anyway. Then we open it up and then we ask them. Yeah. Okay. You go ahead.
All right. So, what did you came up with? As we have discussed, sometimes it's good to use some outcome measurements or some questionnaires to find out where those obstacles to get better are positioned, like in the cognitive area or in the contextual area. And in that way, we can personalize our treatment a little bit better than maybe we did before, only looking at the directional preference and nothing else, or at a certain classification and nothing else. All right?
Okay, yeah. So certainly that seems like a good idea. And also, you know, the question is, can we personally or as a group collaborate more? communicate more with other clinicians, other professionals, to increase some mutual understanding. And perhaps we have something to pass on to these people, and then perhaps we have something to learn from them. I mean, maybe in Czech Republic, everyone is a big, happy family. And between different therapists, different healthcare professionals, perhaps you've already got that covered, I don't know. But that's not the case in Canada, that's for sure.
That's for sure.
That's for sure, in Canada. So, thinking about those three things, you know, I think, you know, we can be a part of the solution if we really are trying to encompass all of these factors that are deemed to be sort of important when we're managing our patients, that we try to collaborate and cooperate, that we do use these screening tools and outcome measures to help us sort of make these decisions and give a comprehensive assessment of our patients. So,
there's no goal, I see.
Do
we got it covered, I think. What we shouldn't do, we shouldn't hang backwards too easily. I think we still can learn, and maybe that's why you're here as well, to learn a little bit more again. Next one. Because I think we are a wheel in that big machine of musculoskeletal therapies, and we have something to add, but we are not the only ones, of course, to be part of the solution. So we are part of the solution, not the whole solution. That's what I wanted to say. So at the end, who thinks of you, give me hands, that he can do a bit better than you are at the moment, maybe already really good, but who can do a little bit better? Right.
That's 96%. It's pretty good.
Right, that's like the diplomats.
That's right.
Yeah, right.
That's the same.
Thank you so much.
That's great. Okay. So now we have a chance for you to ask any questions you'd like to ask. We have a microphone. Yeah. There's a question at the front there.
Maybe more than a question, if you can comment on the fact that, in my opinion, there are some people that don't need to use screening tools, that they have something like, let's say, a talent to understand, to have a deeper connection with the person and realize the contextual factors. Yet on the other side, there are people who, even if they use the screening tools properly, they are not able to convince the patient to, let's say, invest on it. Which means sometimes I get the feeling as if we just cannot screen everybody, and that we are not able to realize what the real contextual factors can be.
And if I may ask you a question, you can't screen them because you don't have time, or are there no like Czech questionnaires? In my country, some questionnaires are only in English, and we don't have them in Dutch, and they don't understand.
No, I don't think that it's because of the language barrier. It is because the people don't want to fill another form.
Right.
For them, it is like, that's not the case.
Overload with a lot of questions, and they are in different questionnaires, they are repeating itself again. I agree on that. That's really difficult. Another thing which I feel in my clinic, where we see mostly chronic pain patients and radicular syndrome patients with chronic, a lot of patients, as soon as you start to hang a little bit towards those psychosocial stuff questions, they start to, well, I'm not crazy. It's not in my head. I have back pain. I have leg pain. So I think it needs introduction as well before you start to ask using questionnaires as well. So, and explaining that, well, you have a back pain, you have a leg pain, and you really need to, we need to take care for that. We acknowledge that. But sometimes the outcome is also influenced by those other factors. They influence your outcome for your back pain. So I don't know if I get it across, but
yeah. I wonder if you were also getting at sort of, if you're really good with your therapeutic alliance, can you get by with that and be sensitive to these factors without necessarily filling out the questionnaires?
Let's say so.
Yeah, and I think, I mean, therapeutic alliance is vital, right? So if you had a choice between filling out the questionnaires with no therapeutic alliance or having therapeutic alliance and not filling out the questionnaires, I would go for having therapeutic alliance and not filling out the questionnaires. But if you can do both, maybe sometimes the questionnaires don't add much, but there's always a chance that there's something that you have missed or not thought about that comes up in those questionnaires that you think, okay, maybe not now, but maybe at some point I can come back to that and address that. So it's these things that sometimes it surprises you. No matter how good you are at communicating and making that alliance, you can't sort of always pick up on everything with all patients. But sometimes there's something in the questionnaire which says, that's really good to know, and that's going to be valuable in terms of how I manage this patient. And maybe I talk about that now, maybe I talk about that later, or maybe I see how the outcome goes, and if it doesn't go well, we start thinking about these things. And so that's what I would say, is that it doesn't it's more important, but it doesn't completely substitute for having that the data to go with.
Maybe making it a little bit more black and white is, of course, way more important or more logical to have that in a very chronic pain situation where the patient just has his 2 days of back pain. I wouldn't go into that with questionnaires as well, right?
Great. Thank you for the question.
Any other questions?
Dobrý den. Já bych se chtěla zeptat, jak jste měli na slajdu nějaké onemocnění, vlastně posuzování procentuální z hlediska toho pacienta, že má nějaké problémy, třeba psychosociální nebo nemoci, tak podle čeho jste vlastně to procentuálně hodnotili v rámci toho dotazníku? U daného pacienta, když jste měli třeba, že byly, nevím, komorbid nemoci, když byly, tak byly nějaké otázky nebo nějaký procenta a nějaký psychosociální.
Okay, so those scales that you saw we used is a real estimation, a very broad kind of estimation. Okay, we cannot be that accurate. And how do we weigh one contextual factor against another contextual factor? I think it's impossible. So those are our general impression of, sure, you know, the cognitive factors seem to be more of an issue than the comorbidities. So it's very general. They're not precise. It's not 41 versus 32. It's very general. And I think that comes with, sure, the screening tools, but also that, you know, developing that relationship and getting that sense from the patient, that therapeutic alliance. Thank you.
And sometimes you can make it a little bit more measurable again with those specific. If you think this patient is really fearful, you can use a questionnaire for that, seeing if you can make a figure of that, and maybe you can measure it later on where you're treating that patient if it's also reducing, if that's the goal of your treatment.
Hello.
Hello.
Thank you for your speech. Do you have in your country some follow-up psychotherapist care, some net or something where patients go on with the care?
Yes, we have. We have, but we are not having that in the clinic, but we have like a network of and mostly it's pain psychologists who are working with pain patients.
And this specialist has a capacity?
Sorry?
Is it free for care or mají kapacity na to ošetření? They are available for treatment?
Well, it's not free of charge. And your question before is even more difficult. Mostly it's very difficult to find them close to the patient. So often there's a lot of, they have to commute for a few hours to get there. And so it's a difficult thing. It's a reasonable question.
In Canada, it is free of charge, but you can't access. There are hardly any of them. So that's our issue here, is finding someone that you could refer someone onto in that circumstance. We just don't have the number of people available, the number of experts available that we can refer people on. That's our problem.
If you look at what we teach now in the ABCD course, it's actually the module of Yannick Toussaint-Laflamme from Canada. And I think the nice part in that module is that he has these two circles falling into each other. The inner circle, which is really simple to address as a physical therapist as well. You don't need to be a psychologist to do that. But it also gives you the items which are really difficult to address as a single physical therapist. So you need a multidisciplinary team, or you need that psychologist. And of course, I'm not able to say, well, you are a depressed patient, but maybe if there is a real depression syndrome, you need to have a psychiatric doctor to get pills and some talking as well, I think, right? But difficult sometimes to get.
But to help with that kind of assessment of, can you deal with it, or does it need someone else? I think once you get those measures and you start to try to manage that patient, and they do respond, they seem to do well and get better, and maybe you retest and some of those factors go down, then it gives you some reassurance that maybe I don't need to refer them on quite so urgently. We'll wait and see how they do. But if they don't respond and you're not making any progress, then it reinforces the fact that these are significant barriers here that I cannot address. I've tried, I've reassured, and we've talked about different factors to try and address them, and I can't. Now I need to refer them on.
To say the bio part is way as important as the psychosocial part. I've seen that in my studies where if I had people with a very high anxiety and depression, and they got an injection, got way less pain, and they could start to move, then all in a sudden the depression and the anxiety was gone as well. So it's interacting with the bio part as well. So we really need to keep an eye on that. Was that an answer to your question?
Okay, I wanted to ask, you said that we have all these guidelines, and we have also McKenzie method, but I think the global burden of musculoskeletal disorders is increasing still. Mm-hmm. Do we have really the recipe for this condition, or do you believe that we already have the solution for this one?
Well, I totally agree with you. We are not reducing it at the moment. It's getting worse and worse and worse. And maybe it's because of the complexity of the society. Maybe it's way more a social thing than anything else. We are searching for that, I think.
I mean, the question is it getting worse because people aren't following the guidelines, or is it getting worse because they are following the guidelines and the guidelines aren't effective in terms of addressing most people's problems?
Yeah, I wanted to hear your opinion on this.
My opinion.
He sticks to the bio. Anyway, you know?
my opinion is I don't know which way round that is. My thought is most people, as you saw from the data by the Joshua Zavro study, that many people are not following the guidelines anyway. So it hasn't really been kind of tested out. If that happened in a community or a country where everyone was clearly following those, then what would be the effect on pain and disability in that country? I suspect that if you took out all the let's just pick on passive care for a second. If you took out all the passive low value care and people were all given advice consistent with those ticks there, I would think that should have an impact. That would be my feeling. Now, maybe not with our expectations of everyone's going to feel dramatically better, but I think it might be better than what goes on now. What goes on in Canada now is a lot of low value, passive care where people are encouraged to continue on with the therapy. That's not good. So I would love to stop that tomorrow. And if people say, well, we're not going to do McKenzie, I would say, well, at least do the guideline care. Let's see how that goes. People are encouraged to be active. They're educated, they're reassured, they're addressed some of the psychosocial stuff. I think that's better than what we've got now. That's my feeling. Does that answer?
Yes, thank you very much.
Okay. Good.
I think it's the last question, Eva. It's
Any other?
almost 3 o'clock.
Yeah, okay. Great. Well, thank you very much for listening. And I hope that's been helpful to some extent. It's great.
Right. Thank you.